All right, so for the next, I guess, 6 hours, we'll talk about congenital heart surgery. We'll do this in 2 segments of 3 hours each. So we have plenty of time to discuss various things and various lesions. Please, if you have questions, maybe send a chat and we can answer them after each segment. This way, the information is still fresh. So this is what we will talk about today. We will focus mostly on the left side of the screen. So the PDAs, coarctations, septal defects, ASDs, VSDs, AVSDs, and then tetralogy. So the cousin of tetralogy, double outlet right ventricle. Then we'll talk about single ventricle. And those are probably the main things for the boards. On the right of the screen are some of the more rare lesions. And we'll talk about those as well. But if you had to focus on anything, I would focus on the lesion. If you're short of time, focus on the lesions on the left, and those also will be the lesions that you'll be asked about on the oral boards as well. On the left of the screen, not PAIVS, but everything above that. So for each lesion, we need to know the anatomy, the pathophysiology, clinical presentations, workup. Most of the workup is going to be an echocardiogram, indications for surgery, and the surgical management. What do you do when and why, and then post-op, some of the more common post-op complications. We need to know the basic lesion presentation, some of the pathophysiology and anatomy, the management, the workup, recognize some of these lesions that have characteristic appearances on chest X-ray or echo or even cardiac cath. They might give you a snippet of an echo or a cath. Know when to do surgery and later on for the boards, the oral boards, how to do the operation. Know some of the common pitfalls and complications of each of these lesions, and certainly CSATs is very helpful. And then the there's also the TSRA had put out a book a few years ago about these various lesions, more for oral boards, but also is very helpful for the written boards. Let's just start with some questions. And this is not, there's no input from your side. So just think about what the right answer is. So what percentage of myocardial blood flow occurs during diastole? So the question is, what's the percentage of myocardial blood flow that occurs during diastole? And those are the answers: 20, 40, 60, 80, or 90. So if you are a board taker, I guess you can probably think that it's probably more high than low, since there are more high numbers than low numbers. But and this is just so you either know it or you don't, but it's about 80%. So 80% of the myocardial blood flow occurs in diastole. And that's why in some lesions where the diastolic blood pressure is low, such as a patent ductus arteriosus, you do have some issues with the heart, but also more importantly, that correlates when you have a BT shunt and a single ventricle. So when you have two ventricles and you have a PDA, it doesn't really affect the blood flow to the heart muscle itself. There's plenty of reserve. But when you have single ventricle and tenuous physiology, and now you have a shunt, say a BT shunt or a PDA, which have the same physiology, the percentage of myocardial blood flow occurring in diastole is going to be important, because in diastole you have pulmonary runoff, meaning the blood will go through the PDA or through the aortopulmonary shunt into the pulmonary circulation. The pulmonary circulation is a sieve, if you will, and a lot of that blood will go back into the lungs through the ductus or through the BT shunt in diastole, and therefore you have less myocardial perfusion, if you will. And again, especially in a single ventricle hypoplast or some of the other variants of single ventricle, that'll be important, because now you have tenuous physiology and now you have tenuous blood flow. All right, let me see if I can move this. Can I move this up a little bit? Probably not. All right. Which statement regarding the aorta and the aortic arch is correct? So we're talking about the aorta and the aortic arch. So the aortic isthmus lies proximal to the left subclavian artery. Let's go through them one by one. So the aortic isthmus, and I'll give you maybe 15 seconds to go through the answers, and then we'll talk about the answers, since we have a little bit more time today than often. So the aortic isthmus lies proximal to the left subclavian artery. True or false? So the aortic isthmus is, so the area of the arch is divided into three segments: the proximal arch, distal arch, and the isthmus. And the isthmus lies distal to the left subclavian artery. So that's false. The most common aortic arch anomaly is a right aortic arch with an aberrant left subclavian artery. So that's a vascular ring, right aortic arch, aberrant left subclavian artery, with usually a left ligamentum or a left ductus. But is that the most common aortic arch anomaly? So most common aortic arch anomaly is just a mirror image branching of a left arch. So it's called a right aortic arch with mirror image branching. It's not a vascular ring. We're not talking about the most common form of vascular ring, which is that right aortic arch, aberrant left subclavian. We're talking about an arch anomaly, which the majority of which are going to be just a mirror image branch, which has no physiologic significance because it's the same. Let's just start from the bottom. And sorry, all these things here. All right. An interrupted arch is usually associated with truncus arteriosus. So is an interrupted arch, I mean, it's associated with it, but it's not the most common version. The most common flavor of interrupted arch is without truncus. A double aortic arch is the most common type of vascular ring. So we talked about that. That's the most common here, right? Aortic arch, aberrant left subclavian, left ductus or ligamentum. So this is the second most common. So then we're left with this one, which is normal anatomy. Ascending aorta arises posterior and to the right of the pulmonary artery, just from basic anatomy of the heart. All right, an overriding AV valve. An overriding AV valve, what does that mean? So again, we'll give you about 15 seconds to go over them, and then we'll go over through the answers before we start the presentations. All right, so an overriding AV valve is seen in single ventricle physiology and some of the unbalanced AV canals. So has chordal attachments into both ventricles. So then now you have to sort of try to remember what's an overriding AV valve and versus say a straddling AV valve. So that's a straddling AV valve is a AV valve that has attachments in the two ventricles, whereas an overriding AV valve, remember in tetralogy, for instance, an overriding aorta overrides the ventricular septum, so it shares both of the things below it. So that's the aortic valve, but we're talking about the AV valve. So so that's not correct. That's a straddling AV valve. They occur frequently together, but not necessarily the same. Must have chordal attachments to the ventricular septal crest. So the crest of the septum is where that VST starts. So, or the interventricular septum. So does an overriding AV valve have attachments to the ventricular septum at its crest, at its junction between the right and left ventricles? That is a Rastelli A classification, which has chordal attachments. So that's not necessarily an overriding AV valve. Can it coexist? That cannot coexist with straddling. Actually, they oftentimes coexist together. Is never associated with malalignment VSD. So anytime you see never and always, that's a red flag. So that's also incorrect. But it does empty into both ventricles. So that overriding valve, whether it's a mitral or tricuspid, will empty into both ventricles. And the typical presentation of that is a patient, say, with double inlet left ventricle, where there is a large AV valve. Sometimes you have two, so sometimes you have one. And that AV valve will override both ventricles and empty into both ventricles, but mostly into the left. the cardiac situs. The cardiac situs is determined by what? So the cardiac situs, this is of the SDS or SDD classification of hearts. SDD is transposition, SDS is the normal. So the cardiac situs, it's that first S, which relates to what? Is it the apex, the RV, RA, LV, or the arch? I'll give you a few seconds here to go over what you think the answers would be. All right, so the cardiac situs is determined by the direction of the cardiac apex, meaning levocardia or mesocardia or dextrocardia? No, that's so different. It's the apex of the heart is unrelated to situs. Because you can have a normal situs, you can have situs inversus or situs ambiguous. Those are the three types of situs, and those are not really related to the apex of the myocardium. The position of the right ventricle. Well, the right ventricle could be on the right, could be on the left of the myocardial mass. In corrected transposition, the RV is a left-sided RV, but that doesn't really determine the situs necessarily. The position of the RA, the LV forming the ventricular apex. So sometimes you don't have an LV and you still have a situs, so that's incorrect. The sidedness of the arch, well, that determines some, whether it's a right arch or left arch, that determines other things, but this is the right answer. The position of the RA, morphologic right atrium, not the right-sided atrium, but the morphologic right atrium, that is what is going to be determining if it's a situs solitus or situs inversus, or sometimes you have situs ambiguous. You cannot really tell what the situs is, and that's mostly in heterotaxy, so a complex set of lesions in congenital heart disease. All right, what vascular structure has the highest oxygen saturation in the fetal circulation? So we're talking about the fetal circulation, and you have to remember what is the structure that has the highest oxygen saturation. Well, it's the structure that's coming from the placenta, right? So then which one of these is the structure that's coming from the placenta? So the aorta, ductus, arteriosus, and I'll give you a minute here to think about it. So is it the aorta that has the highest oxygen saturation, or is it the ductus arteriosus or ductus venosus? I mean, none of these really have the highest oxygen saturation. So it's one of these other ones, either the umbilical artery or the umbilical vein, and you have to sort of try to figure out which structure is the one that is coming from the placenta and which one's going to the placenta. And the umbilical vein is the structure that's coming from the placenta into the patient. And the umbilical artery is the structure that goes from the patient into the placenta. All right, which one of the following arteries supplies the SA node? And that's should be fairly straightforward, I think, but I'll give you a few seconds here. All right, so the structure that's associated with the SA node is the right coronary artery, right? All the other ones don't really supply the SA node artery. And when you're doing a procedure, say a superior approach to the mitral valve, that can damage that SA node, and you can get a junctional rhythm. So that is one of those things that sometimes can happen. And that's why it's important to remember that. All right, of the following choices, the least likely complication following blunt cardiac trauma. So blunt cardiac trauma, which ones of these is the least likely complication? All right, so we're talking about blunt, not penetrating. VSD, can you have a VSD from blunt trauma? Yes. Papillary muscle rupture, yes. Coronary artery thrombosis, you can with cardiac contusion. Cardiac free wall rupture can happen, and you're basically dead in the field. And ASD is not a. It has been described, but it's not a common complication following cardiac trauma. All right, with those questions, maybe a bit harder than the boards, but we'll start. We'll start. All right, so PDA. See if I can get this off. Probably not. Huh? All right. So a PDA is. Move it to the side. All right. So a PDA is here's the pathophysiology. This is an autopsy specimen. Oftentimes, there's a smaller opening in the pulmonary artery, and there's this is the pulmonary artery, and this is the aorta, and that's